I hope everybody's having a great time at the meeting. Thank you for choosing to spend your Saturday with us. I am Sarah Louden, founder and CEO of Total Health. I always get so inspired when I see people spending time investing in education. As my team walks around with a little gift, I want to just explain before I kick off this panel what we are giving. Today we had such a beautiful testimony by a patient, and I think sometimes, we all have patients that we see, but sometimes listening to someone else's experience, or maybe not having your clinical hat on where you're trying to decide what you're going to be doing as an intervention for patients, sometimes it just puts things into perspective that this person had a collision with disease, and this is the way she's choosing not only to manage it, but to use her voice to empower others. I was so inspired by that. And the gift that the team is handing out to all of you, you'll see my little boy, Joseph, here. We have a neighbor in our neighborhood, and Joseph goes to school with the boy that I'm going to talk about. Well, one day he was riding home with Joseph on the bus, and he said, "Oh, I got to tell you something about my mom." And Joseph said, "What?" And he said, "Oh, my mom has And he didn't, it was a secret, meaning he wanted to say it, but he knew the family wasn't sharing it. And ultimately he told Joseph, cancer. And Joseph was like, "Oh no." He said, "My mom trains doctors and nurses in cancer. You should have her talk to her." Anyway, right around the time, Gilead had come out with this incredible book called The Adventure Jar. And it is written by a mom with cancer to her children. And Joseph and I read it at our dining room table, and I said, everybody has to have this book. Everybody has to have this book. Why? Because as you heard from the patient today, the day before you're normal. The day before you're thinking about what you're getting at Costco. And then you have that diagnosis call or that diagnosis visit, and everything changes, everything shuts down. And one of the things that shuts down is our ability to communicate with our children, because we're terrified. So we don't want them to be terrified. And just like in the case of this family friend, they chose initially to keep it a secret. And that puts undue stress and pressure on the kids, because they need somewhere to put that energy, because they're scared. So we want to gift you the gift that we got from Gilead, and we want to ask you to pay it forward to someone in your clinic, in your practice, in your life that may need some way to learn how to communicate with children. It also would be a great waiting room book for people to be able to pick up and see. It is free and available on Gilead's website, which we will put in the app, or we will send with the after the meeting. So we just want to say thank you to Gilead, and we definitely want to thank the patient who shared her testimony earlier. So today I am tasked with moderating what I think is going to be a really great panel, because one of the things I always say, people always kind of say, "Oh, as a woman entrepreneur," and I'm the first in my family, I'm the oldest of four. My dad was a cardiologist. My mom is a nurse. She's been a nurse for 45 years. She came from Trinidad, went to England to do her training, and then moved to New York. And I feel like she started working immediately and raised a family of 4 kids and balanced things that I honestly don't know how she balanced. And people always say to me, "Oh, you're like a female founder or a female entrepreneur, or maybe you want to talk to other women." And I always reject that notion, because I think my message, and all of our message, whether you're a older white man, whether you're a younger Indian man, whatever the message is, it's our message. So it shouldn't be kind of isolated or insulated to just our peer group. But at the same time, I think that sometimes we forget that there are groups that may be balancing burdens differently. And it's important not to give the seat of, "Well, I can't do it because," fill in the blank, but I do it despite fill in the blank. And we get really to empower each other through our own stories. So I love these three women. I have watched their careers over my own career in oncology, and they are all so inspiring. They each come with their own stories of their journeys, and today we're going to just kind of go through some questions that I think will apply more than just women in oncology, but all of us who are balancing our very busy lives with our very important personal lives. So I am joined by Dr. Reshma Matani, Dr. Ruta Rao, and Dr. Rita Nanda. For this, I'd like to call all of you by your first names, please. And we're going to just almost have a discussion, share experiences, challenges, and solutions for women in oncology. As I was doing research for this, I found a lot of kind of supporting information that broke down ultimately that oncology in itself is still largely male-dominated, and the higher in leadership you are, the more male representation there is. I also found a lot of studies, and I have a great family friend who's a breast surgeon here, so even though I know his breast surgery is perfect, there was a study that showed that female breast surgeons, patients, have better outcomes. And the question was, why? Like, what could be contributing to that? Could it be that they're listening differently? Could it be that when they're communicating things like whether you get a lumpectomy, whether you get a bilateral mastectomy, that they empathize differently with how they're communicating versus kind of more rigid? There was a lot of hypotheses about why this could be, but I found it really interesting that we could quantify that outcomes were better for patients who were seen and treated by female breast surgeons. So that also kind of started to pique my interest in, well, what else? How else could women almost, as they elevate into leadership and start using their voice from the clinic all the way to the boardroom, how else could we start to impact and affect outcomes? One huge way is advocacy. You look at cancer advocacy, even the highest ranks, like the past executive director of the American Cancer Society, Karen Knudsen. In many other disease advocacy groups, those top positions are seated by men. But in oncology, when you look across the advocacy leadership pipeline, it's a lot of women. So we find that in cancer advocacy, women often lead efforts in patient-centered care, in survivorship, and in addressing disparities. And when there is an intentional focus on those areas by these women-led advocacy organizations, we not only see statistics represented, but we see statistics changing over those people's leadership time. So as I start to talk to these incredible women on my panel, I want you to kind of keep in mind that the undercurrent of this is why having representation by women is so important, that it's not just equity or equality, that there's something there that these studies are showing matters and is meaningful to patients. So I'm going to start with kind of a global question, and I'll start with you, Rita, since you're closest to me. What inspired you to pursue oncology, and did you have any female role models early in your career?
All right. So, yes, I can answer the second part very easily in terms of female role models. So my maternal grandmother was a physician in India. She had started her own maternity hospital and delivered babies, and that's where I was born. And so my mom was a physician, my dad. So I come from a long line of physicians. So I think that's what really inspired me to do it, to know that, you know, she could have done it at that time when there were probably 2 women in her medical school class.
Wow, very good. I'm going to get back to that to say, did you ever feel pressure about going into the field because of that?
No, my parents were very clear that do what you love, and you know, but I have 2 younger sisters, neither of them went into medicine.
Good, okay, wonderful. Okay, Reshma, I'll go to you.
So the question is
what inspired you to pursue oncology, and did you have female role models early in your career?
So I think the thing that inspired me to go into oncology is that I'm easily bored. I feel like oncology is unique in that it's a field that is constantly changing. It forces you to be a lifelong learner, just like we've learned today. Just keeping up with the data, it's challenging. We only treat breast cancer, and there's so much to learn. And I think the part that really drew me to it was that feeling of always needing to stay up to date, learning. And then I think the other aspect of oncology that really attracted me to the field was the relationship with patients. I think when you stand side by side with someone at a time that's a very vulnerable time in their life, it creates a bond like no other field in medicine.
Did you have any early female role models?
So actually, surprisingly not. In fact, I gravitated more to male role models, and I had mentors that were men. And I don't know if that just was happenstance, but I found personally that actually women were not as kind to me, were not willing to lift me up. We're not, I think as women, sometimes we're our own worst enemies. That in fact, male role models were much more factual with me, much more objective, and I had a hard time connecting with women as role models. And I think that experience has stuck with me, and I've been very intentional in being different with the people that I mentor.
I love that because I think part of maybe what roots that is we want to be soft communicators. We don't want to discourage with the things we say. So sometimes it's like, no, that dress makes you look beautiful. And meanwhile, you're like, don't wear that dress. But I think that there's a part of that you never want to knock someone down, and you can't really navigate the boundary until you learn to use that part of your voice. Mm-hmm. So I love that what you took from that was, I'm going to learn to use that part of my voice to be a better mentor. Rita, how about you? What inspired you to pursue oncology, and did you have early female role models?
Yeah, no, I think great questions. I think for me, like many people who go into oncology, it was personal family exposure to cancer. My mother was diagnosed with cancer when I was in college, and I think that I always knew, I think, that I wanted to be a doctor, even though I come from a family of engineers, and I was an engineering major in college, but, kind of went with the goal of potentially going to medical school. And I think that, that experience really shaped me and helped push me towards oncology. And so when I was a medical student, I rotated through all the different oncology subspecialties: radiation oncology, surgical oncology, medical oncology, gynecologic oncology. And I just felt like Reshma did, that the relationship in medical oncology that we have with patients is one of kind of almost being their primary care doctor, that we have an ongoing longitudinal relationship with patients, and we really become that primary for patients. Because with surgery, it's a shorter period of time. With radiation, it's generally a shorter period of time. But with med-onc, we have that ongoing relationship, which I think can be really fulfilling and nice to see patients through some of the toughest times in their lives. For me, yes, I did have very strong, actually, female mentorship. But I will share a story I think that I've shared with others before. When I was a third-year medical student, I knew I wanted to do medical oncology. I went to the section chief of Hem-Onc at the University of Chicago and said, I want to do oncology. I'd like to get involved with research, and pointed me to a few different people, and that's how I found my female mentor slash sponsor, probably more of a sponsor than a true mentor, and has really opened up doors for me and supported me. And then as I've become more independent, kind of the growing pains of that relationship, I think of her as my work mom, but the fighting with your mom when you're fighting for your independence has kind of come into that relationship. But again, I have had strong female mentorship. But just to your point of sometimes women are our own worst enemies, I was at that point in my career where I wanted to advance in the breast cancer program at my institution, and I wanted to take over the directorship of the breast oncology program. I'd kind of been working towards that, and had a female tell me that perhaps that role should go to a male because Dr. X or Dr. Y was really challenging, and maybe a male leader could manage that relationship a little bit better. So, I mean, I just have to say I was floored, and I spoke up because I was so upset. But it does happen, and it's really unfortunate that it happens.
Yeah.
But fortunately, that was not my primary mentor, so I was like, I don't care.
Yeah.
And I just, and if anything, I think it drives you, and I do think it shapes how you want to mentor people moving forward, because that is not the type of relationship I would want, and I wouldn't want to be, mentoring people in that way.
Yeah, and I think that also brings up a point that, when you encounter people that maybe have had different experiences, like that could have been driven from fear. Maybe she tried to take a shot at something in her life and kind of was put. So I always try to think too, as I navigate through how do I receive mentorship and give mentorship, I always try to think of the intention of the person. Maybe it's that they're trying to save me from hurt, but they don't necessarily know how like gritty I am or something. So I think it's important too for us to kind of balance that in our communication, or like so appropriately what you did, spoke up. This isn't how I feel. This is actually what I want. So I think that's great. Okay, we hear so much. There's like sessions in so many med-ed conferences, and I think there's even now conferences around it. Burnout being a real issue. It says burnout is a real issue in oncology. I'd argue burnout is a real issue in life right now. But do you think, Rita, I'll start with you, do you think gender plays a role in who experiences the greatest amount of burnout and how they experience that burnout?
Me or
Yes, Rita, sorry.
I think burnout is there. I think, as physicians, clinicians, the EMR is a big source of burnout, I think, for all of us. Like the documentation and all of that, like just getting wrapped up in all of that. I think also, learning how to say no, which I'm not very good at. Of course, I would never say no to Reshma because, I'm here. But, like picking and choosing what you say yes to, and prioritizing those things that are important to you. Obviously, if there are, balancing family, outside social responsibilities, and work, it's hard. And I think we all struggle with that because I think we're all overachievers and want to do everything, but it's always impossible to do everything well. And so it's, I learned this my freshman year of college, selective neglect. That was the phrase that I learned. You cannot do everything, so you pick and choose what you're going to prioritize, and then just neglect those things that are lower priority and not focus on those. So.
Reshma, I'll tell you, as I was talking, I had a group of doctors from different specialties, not just all in oncology, and we were talking about this issue because we were thinking, like, what if we built this retreat in Sedona for burned out oncologists, and there was a dermatologist at the table, and he's like, I have no idea what you guys are talking about. He goes, I want to take something off your plate because I'm empathizing with where you all are, but do you think, to that point, that you feel it differently in oncology because you do have the patient that you come home with in your mind?
I think, it's such a fine balance and a careful line that we constantly are towing, that the thing that makes us good oncologists and makes us really value our work can also be very detrimental to us as an individual, because we have that caring, we have that empathy. And when you have to give bad news to someone, we're all human, right? You take that home with you. But there has to be some opportunity or some kind of mindfulness that, okay, now I'm walking in the door to my family, and I have responsibilities to them, and how can I segment this part of my life? And I think for me, the thing that has really helped me is to stop feeling guilty about time that I take for myself.
Yeah.
Right?
That's
back
big.
to your point of saying no. Sometimes the answer's no. It's just, I can't do it. I don't have to explain why I can't do it. I don't have to say I have a conflict. I'm not available.
Yeah.
It's a complete sentence.
Yeah, I think that should empower a lot of us too in work scenarios, even in family scenarios. And so Ruta, thinking about that, how does it look when you are having a particularly difficult day? Maybe you gave some devastating news to someone that you felt an emotional connection to. How do you reset your energy before you walk into the door for your family?
So I think it's For me, it's been really important to have a group of people that I work with who understand. So I think, we all have wonderful nurses and other members of our team who also went into oncology to have these relationships with people, and I feel like sometimes we cry together.
Yeah.
And then that lets me really sort of release those emotions. I have people who know some of my patients as well as I do, so they know when I'm going to give bad news to this patient, how devastating it is for me, how much it is for the patient, how much it is for them. So I have them to lean on at work for that support, and that lets me kind of deal with it at work and try not to take it home.
Do you have advice for maybe someone out listening that doesn't have that kind of avenue to let those emotions out? Is it vital for them to find it, or is there a way they could find it kind of internally? And going back to what Reshma said, maybe segment mentally, this happened in that part of my life, but now I'm walking in to find out how was the English test today.
Yeah. So I think, everybody's different, and I think you have to find one of those two ways to deal with all the emotional baggage that we carry from the patients that we take care of that, like both of you said, that we really care about, especially over these years that we've built these relationships with them.
Yeah. It's a hard thing.
Mm-hmm.
It's a hard thing to balance, and I think it's different like season to season of our lives too. So yeah, it's definitely something, but the takeaway is you have to pursue it because burnout is real. And once you experience it, it's almost like you're in too deep. Now you've got people that are depending on you, a spouse, a partner, children, your patients, maybe you're taking care of your aging parents, friendships. And sometimes it just means like raising your hand and saying like, I just need a little bit of help. And I think that for high achievers is hard because we don't want to let people know that we need a little bit of help. So I would just encourage you to find that type of communication channel. So Total Health just turned 10 this year, and as I mentioned, we are a woman-owned and really a woman-powered, although we do have some guys that we always tell that there are token guys in the business. But, and they, ironically, they like take care of the money, they take care of the things that maybe we'd go overboard in spending. But one of the ways I've seen the role of women in oncology evolving is we're talking so much more about it. Like, I feel like if you go back 10 years, there wouldn't be conferences like LEAD, or like I know Shika has a conference, Women in Leadership Conference. I feel like we're talking about it more, and like we have permission to talk about that there are issues that maybe the two groups are facing differently. How do you see the role of women in oncology evolving maybe in the next 10 years? Reshma, I'll start with you.
Well, I think that if we identify this now as an issue, we have to be very intentional in figuring out what the plan or the path is going forward. So for you, I see you putting that into practice with Total Health every day in terms of the selection of speakers in the topics that are included on the agendas and making them relevant for all physicians and other members of the healthcare team, being inclusive, being intentional, and about not having, what do you call it, manels?
Yeah, Manals.
Manels, right? So I think you're living it and you're doing it. So going forward, I think we all, as we design these agendas and think about who to ask to speak, we need to make sure that we're representing a broad view.
And Rita, do you think that you're making those same types of leadership decisions? Like, are you being intentional saying, if I look at a candidate pool, do you look and say how many of these are women, maybe how many of these are people of color? Or is it more that you are saying, I'm looking at the candidate pool very in a binary ways that maybe don't factor those things in?
Yeah, I mean, I have to say, as I've hired 3 junior faculty, soon to be 4, in the last 4 years, and 3 of them are female and 1 male. I think that there are a lot of top-notch female candidates for everything out there, people of color, people of different racial, ethnic, socioeconomic backgrounds. I have been involved with like ASCO in San Antonio, planning for the meeting, and we do think a lot about, And I think in breast cancer, it's somewhat easier than, say, something like cardiology or general
Right.
surgery. There are so many, the people who are in the field are of very diverse backgrounds.
Yeah.
You know, surgery is a very male-dominated field still. And so, you know, what you're seeing here in oncology, when you go to San Antonio, you go to ASCO, at least for the breast cancer sessions, you know, if anything, there are probably more women
Yeah.
than there are men on the panels. And so sometimes we have to dial that back and be like, oh, this is an all-female panel. We probably need to throw in
Yeah.
a male.
Our
you know,
token guy.
Yeah, our
Yeah.
token guy. So, you know, it's really interesting. But in breast cancer, I feel like we are very fortunate that, you know, we have a lot of diversity. And if anything, we have to think about including men in our panels.
Yeah. Ruta, how do you think how we talk to our children shape the limits or boundaries of what they think is possible for them in the same way, like, you know, you kind of tell your boys be rough and tough and you tell your girls be like gentle and sweet. Do you think that the communication early on that you can be anything you want, kind of like how, you know, with your experience, do you think that has a major role in what these young men and women, these young boys and girls grow up to be as men and women?
Yeah, absolutely. I think it's not only, though, how we talk to them, but also, you know, what we do and how we're practicing what we are saying. So how we're in our careers, how we're in our personal lives, because I think they view us as their examples and they see, you know, this is what mom is doing, this is what dad is doing, these are the things I can do too.
Yeah, yeah, I think that's a great way of thinking about it. Okay, my last question to round out the panel is, if you were speaking with 16-year-old you, what is one thing you would tell her to remember as you look back on your lives and where you are now? Rita, I'll start with you.
Oh gosh, I don't even remember. 16 was so long ago. I mean, I think I was pretty motivated when I was 16. Through grade school, I was not, and all of a sudden high school hit, and I kind of got my act together. I think my parents were scared I was never going to go to college, but you know, I think I would. I mean, I think that this is the career that I would have wanted to have at 16. So, you know, I think I would just reassure myself that, you know, there are hard things that we have to do along the way, and we have to make some important decisions along the way, but that, you know, I can do whatever I want to do.
Yeah, trust yourself. Definitely trust yourself.
Yeah, I
Reshma, I'll
think
go to
that's
you.
a general theme, right? That's an age that there's a lot of self-doubt.
Yep.
So I think if I could look back, I would probably give my 16-year-old self some assurance that it's all going to work out, that, you know, there'll be tough times, moments of exhaustion, moments of sacrifice, moments of self-doubt, but grit will take you through and support will lift you up.
Yeah, I love that. And Ruta?
I would say exactly those things that they said.
I think that 16-year-old all of yous would have been great friends. Well, I thank everybody for listening to this panel. I hope that it's been helpful to you in good ways. And if you've got girls at home, please go back and tell them about these three incredible women and the things that they've done, the heights that they've achieved in oncology. And tell your boys to encourage. I'm a boy mom. Tell your boys to encourage their girlfriends and their friends that everything's possible. So I thank you all for your time and attention for the panel.
Thank you. I'll go ahead and introduce our next speaker. Dr. Mehta will come back up to the podium, and he'll give us a presentation on integrative medicine. Thanks.
Good afternoon. Hello again, everybody. And thanks to Dr. Mathani, Dr. Iyengar, and everyone on the Scientific Planning Committee for their kind invitation to talk about a topic that I'm very passionate about. And I really appreciate the attention to topics that aren't oftentimes discussed during the course of the morning and the afternoon, particularly as it pertains to professional burnout and individual burnout. You know, I'm really intrigued by the science of positive psychology and what types of behaviors lend themselves to greater resilience and just greater sense of well-being, both physically and mentally. And this concept of I'm an internal medicine physician by training, with a subspecialty area in sleep. And in sleep medicine, we're oftentimes talking about this psycho-emotional residue that we carry from one environment into the next. So that's one of the reasons why sleep hygiene is so important, is because if we are, watching the news, for example, in bed, bright screen electronic device, which, by the way, all of our bright screen electronic devices are scientifically designed to stimulate the arousal center of the brain, preventing endogenous internal melatonin production, thereby disrupting circadian rhythms, because as long as our eyeballs are on screen, somebody's making money somewhere off of advertising. So they're not concerned about your psycho-emotional residue. But if we're watching the news in bed and then clicking off the remote and expecting us to our brains and bodies to drift into blissful oblivion and accessing those deeper and more restorative stages of sleep, it's just not, body's not designed to do that. So this psycho-emotional residue concept is incredibly important as we go from one environment into the next, whether it's our home environment into the work environment, and conversely from the work environment, or even driving on the streets of South Florida, before we carry that emotional, psychological residue back into our homes. I oftentimes find myself doing some mind-body medicine techniques in my own car, in the driveway, before I carry all that back into the home with me. And my wife, we just got married in December. She's here. She's an oncologist. Her name's Mary, and she's very sensitive about our respective entries into the home. We usually take about 5 to 7 minutes to usually wash up, change our clothes, and just kind of decompress a while before even interacting with each other. And then let's talk about our day. So, being cognizant of these psycho-emotional residues and how they really impact our overall health and well-being is a really important topic in integrative medicine. And what I'm going to be talking about is the latest update on the guidelines. What does the science show about integrative medicine, particularly as it pertains to the treatment of anxiety and depression? So, something you've heard earlier today. The wind picked up. It seemed like the earth and the ground below my feet crumbled away, and I was overcome by a sense of fear, a sense of anxiety, and sadness, as well as even anger. And that was Wendy. Wendy, when she was sharing her very heartfelt and moving story, she shared this. And I think it's a really telling example of how prevalent anxiety and depression is within the population of individuals who are living beyond breast cancer, and their families and caregivers, by the way. So it's incredibly important to understand what are those non-pharmacologic methods of improving quality of life by using integrative modalities to address anxiety and depression. So I have no disclosures, and really I'm going to be giving you a broad, high-level overview of what can we do in our clinics in order to promote better wellness, resilience, and well-being with non-pharmacologic methods of addressing anxiety and depression. And I'm going to be talking about how integrative medicine therapies can play a role in managing anxiety during treatment, after treatment, depression during treatment, after treatment, and then also there was a subsection within the guidelines that talked about procedural or pre-procedural anxiety as well. So, these clinical practice guidelines, this was actually the first time that I had the opportunity to participate in publishing and developing the clinical practice guidelines. I had the opportunity to present them in ASCO last year. And they were designed to kind of dovetail off of this wonderful publication, which is really, this is the mainstream medicine approach to treating anxiety and depression. So, as I mentioned in our earlier dialogue with the panel, integrative medicine is not alternative medicine. It's not designed to supplant or substitute the mainstream treatments for anxiety and depression, but rather complement it. So I do want to make sure that we are all clear on that. So, the intervention that really that really carried the flag throughout the course of these clinical practice guidelines, if there's one theme that we should all take away, it is that mind-body medicine interventions really are supported by high-quality evidence for both anxiety and depression, both during treatment and in the survivorship period. And then there was also very good evidence for yoga during cancer treatments. Additionally, music therapy, relaxation therapies, and reflexology also may be offered for anxiety and depression. And finally, hypnosis and lavender essential oil inhalation for anxiety during diagnostic and the pre-treatment or peri-procedural anxiety as well. So why is this important? Well, this is important because anxiety is incredibly prevalent among cancer patients. Approximately 17.9% of 50,000 longer-term cancer survivors self-reported elevated anxiety symptoms according to a meta-analysis of 44 studies. The rates of anxiety were understandably higher at the time of diagnosis and subsequently decreased somewhat as individuals transitioned to active treatment. And that also kind of makes sense when you know that someone knowledgeable is in your corner, you have a care team developed, and they have communicated what the marathon ahead of you looks like. There is a slight reduction in that anxiety. We also know that anxiety significantly impacts quality of life, adherence to treatment, cancer survival, life expectancy, and associated treatment costs. And one of our goals in our integrative medicine program is actually to prevent any treatment interruptions also that can derail a really well-crafted treatment plan for our patients. So pre-procedural anxiety, one study in the population of patients receiving radiation treatment found that between 10 and 20% experienced symptoms of anxiety prior to their treatments. And talking about switching gears to depression, in a systematic review of over 210 studies, it was revealed that the prevalence of depression was about 21.2% across a vast majority of cancers. So 73% of depressed cancer patients do not receive appropriate psychiatric treatment, and only 5% see a mental health professional, which is another reason why it's so important to kind of take a full thickness approach to precision oncology as it pertains to treatment of breast cancer. And oftentimes, opening up that conversation about mood. Remember, the sort of central pillars of an integrative approach are food, mood, move, and snooze. So food, nutrition, hydration. Move, which is the movement, exercise as medicine. Snooze, how are you sleeping? How refreshing and restorative is your sleep? And mood, what is your psycho-emotional state? Are you cognizant of the residue that you might be bringing from one environment into the next or into your home environment? So it's really important to kind of use all of those methods when we're opening up the conversation of quality of life in the context of treatment. So it's really important that we improve. Collectively, let's all, within this room, make it a point to ask about mood and anxiety and depression for our patients. And sometimes even just opening up that conversation is a really nice opportunity to improve quality of life. So severity of depression among cancer patients is influenced by factors such as functional status and level of social support. That also kind of makes intuitive sense. Depression is associated with suboptimal cancer treatment adherence as well as poor survival. So again, this treatment adherence or minimizing treatment interruptions is another theme here with depression. So, our guideline questions were, what integrative therapies are recommended for managing symptoms of anxiety experienced after diagnosis or during active treatment in adults with cancer? What integrative therapies are recommended in managing symptoms of anxiety post-treatment in the survivorship period? And what therapies are recommended for depression during treatment, after diagnosis, and also in the survivorship period? And it started by doing a very comprehensive literature review. This was a very international and multidisciplinary expert panel. And the recommendations were developed through a systematic review of evidence identified via online searches. And we queried different databases such as the PubMed, the Cochrane Library. Minimal sample size of these studies was an N of 50, and adults with cancer experiencing symptoms of anxiety and or depression during any stage of their cancer trajectory were selected as the inclusion criteria. Integrative interventions for anxiety and depression management, we'll talk a little bit about what the definition we used for those. And then changes in symptoms of anxiety and depression measured by validated tools, validated instruments, reported as either the primary or secondary outcome. And so the broad total of studies that were used in the denominator of this query was 5,144 publications were identified in the total literature search, and after applying the eligibility criteria, only 30 systematic reviews and meta-analyses, as well as 80 randomized controlled trials remained. So that just tells you that a lot of the science that is published in this field, it's got a long way to go still. So these were a lot of the interventions that were demonstrated to have inconclusive evidence. Now, inconclusive doesn't mean that you shouldn't be recommending it ever. It just means that these types of modalities may not be ready for prime time as it pertains to how we are counseling and educating our patients. So it's a really nice list. So stay tuned for better research on these modalities and methods. There was a study quality assessment that was also done. So study quality was rated as high, moderate, and low, or critically low. And there was also comments on risk of bias that were shared among the panelists. This was our method of definition of integrative therapies. So we've got energetic therapies like Reiki, magnets, therapeutic touch, biologically based therapies. This includes herbal supplements, therapeutic foods, dietary changes, manipulative and body-based therapies. This is massage, chiropractic, osteopathic medicine. Mind-body medicine techniques include yoga, tai chi, and alternative medicine systems, including homeopathy, naturopathy, traditional Chinese medicine, Ayurveda. I bring this up because, another concept of integrative medicine is to bring the wisdom of ancient healing traditions from all over the world together in a very science-informed way to improve quality of life. And I think that that's one component that kind of differentiates, the cultural respect that we try and deliver during our communication. We try to get a sense for what types of preferences our patients may have for whether it be Tai Chi or yoga, because oftentimes, belief, just in the clinical setting, belief is a very powerful thing. So if our patients really believe that this type of mind-body medicine intervention is going to help, we say go with it, because mind-body medicine interventions are actually quite a broad umbrella of interventions. They include breathing exercises, guided imagery, creative visualization, affirmations, a gratitude practice, writing in a journal. So mind-body medicine techniques are very broad, and this research, or the deep dive that we did into this research, this body of research, was really instrumental in clarifying which of these methods might be more effective compared to others. So these were the quality of evidence ratings, high, intermediate, low, and insufficient. And then there was also strength of recommendation ratings, which included strong, moderate, and weak. And so, cutting to the chase, these are the recommendations. So remember, the recommendations were kind of categorized in active treatment, post-treatment, or in the survivorship period, and then active treatment, but also more specifically tailored towards the perioperative, peri-procedural type of symptom setting. And what they found was, of course, there was very strong evidence and high quality evidence for mindfulness-based interventions. So again, that's the take home. Recommendations for integrative therapies to manage anxiety after diagnosis or during treatment. Recommendation number 1.1, which is probably the strongest recommendation within the guideline, was that mindfulness-based interventions should be offered to people with cancer to improve anxiety symptoms during active treatment. Recommendation 1.2 was about yoga. Yoga may be offered to people with breast cancer to improve anxiety symptoms during active treatment. And this was, the quality of evidence was intermediate, the benefits outweigh the harms, and strength of recommendation was moderate. I'm going to be going a little fast through these because really I would like some time for interaction and questions at the end. Hypnosis was also looked at. Hypnosis may be offered to people with cancer to improve anxiety symptoms during cancer-related diagnostic and treatment procedures. So this was the perioperative, peri-procedural symptom setting. And the quality of evidence was intermediate, the benefits outweigh the harms, and the strength of recommendation was moderate. So recommendations for the recommendation 1.4 looked at relaxation therapies. Now, very broadly, relaxation therapies include things like progressive muscle relaxation, breathing exercises, and these techniques may be offered to people with cancer to improve anxiety symptoms during active treatment. Recommendation 1.5 was about music therapy or music-based interventions that may be offered to people with cancer to improve anxiety symptoms during active treatment. Reflexology may also be offered to improve anxiety symptoms during active treatment. And just notably, the quality of evidence was low here, but the benefits outweigh the harms and the strength of recommendation was weak. So you can see how already we are now in low quality evidence as well as kind of weak recommendations. And this is just a summary table for managing anxiety during treatment. This is a broad overview of the details that I just covered. So recommendation 1.7 was looking at lavender essential oil inhalation therapy, which may be offered to people with cancer to improve anxiety symptoms during cancer-related diagnostic and treatment procedures. And switching gears to now post-treatment. So we're now looking at in the survivorship period. This is also, again, mindfulness-based interventions should be offered to people with cancer to improve anxiety symptoms post-treatment. And this was the strongest recommendation in the guideline, supported by 7 meta-analytic reviews published since 2017. Particularly important for people living beyond breast cancer and breast cancer survivors, it is important to note that yoga may be offered to people with breast cancer to improve anxiety symptoms post-treatment, and the quality of evidence was intermediate, the strength of recommendation was moderate, benefits outweigh the harms, and just a qualifying statement that for people with cancer types other than breast, the quality of evidence is low and the strength of recommendation is weak. So the good news when it comes to breast cancer is that there's a lot more research on modalities such as yoga to guide our recommendations in this setting. And recommendation number 2.3 was that acupuncture may be offered to women with breast cancer to improve anxiety symptoms post-treatment. Also, Tai Chi Qigong may be offered to women with breast cancer to improve anxiety symptoms post-treatment. Reflexology, we've talked about it briefly in the previous guideline. Reflexology may be offered to people with cancer to improve anxiety symptoms post-treatment, and this is, again, a summary table. So switching gears now, or actually diving a little bit deeper into the inconclusive category. So there are a lot of other commonly used and accessible therapies that require additional well-constructed randomized controlled trials, such as healing touch, therapeutic touch, natural health products, creative arts-based therapies such as art therapy, dance and movement therapy, and then all of these other categories depicted in the slide. So these modalities all got the grade of inconclusive evidence to really make any substantial recommendations. So it's important to note that despite the lack of well-conducted randomized controlled trials, these therapies are generally safe. Therefore, individuals considering them to manage anxiety and depression during their course of cancer care may experience some benefit. Additionally, there's a notable lack of research involving individuals with cancer types other than breast. So again, a good indication that our research in this area is more advanced in people who are living beyond breast cancer. So switching gears now to depression. Depression, as we mentioned, is a very prevalent symptom within or condition within people who are living beyond breast cancer, and again, the guidelines were categorized into during active treatment as well as in the survivorship period. And once again, you can see that mindfulness-based interventions really carried the day. High quality evidence as well as strong strength of recommendations. So recommendation 3.1 is that mindfulness-based interventions should be offered to people with cancer to improve depression symptoms during active treatment. Very strong evidence. Yoga may be offered to people with breast cancer to improve depression symptoms during active treatment. So again, yoga is much more, the strength of evidence for yoga is much more powerful within the people who are living beyond breast cancer, which is nice to know. And the qualifying statement again is that for people with cancer types other than breast, the quality of evidence is low and the strength of recommendation is weak. Music therapy or music-based interventions may also be offered to people with cancer to improve depression symptoms during active treatment. Relaxation therapies, again, I mentioned progressive muscle relaxation, breathing techniques, may be offered to people with cancer to improve depression symptoms during active treatment. Reflexology as well. Here, the quality of evidence was low and the strength of evidence was weak, but it found that we generally assessed that benefits were outweighing the harms. And a nice summary table for you. Now, looking at depression post-treatment. Once again, This was the second strongest recommendation in the guideline, which is that mindfulness-based interventions should be offered to people with cancer to improve depression symptoms post-treatment. Yoga may be offered to people with breast cancer to improve depression symptoms post-treatment. Again, here, another indication that yoga is a close second to mindfulness-based interventions. Tai Chi and Qigong may be offered to people with breast cancer to improve depression symptoms post-treatment. And again, quality of evidence is intermediate and the strength of recommendation is weak. But it was generally considered that the benefits outweighed the harms here. Notably, expressive writing should not be offered to people with cancer to improve depression symptoms at any point in the course of care, simply because it didn't work. It wasn't found to be effective. This is a summary table again, and now I'm going to get into a little bit of the clinical resources. How can we practically apply some of these guidelines into our day-to-day practice? There's a really nice summary article here, which was a question and answer, effectively, that covered a broad overview of the recommendations. How can people access these therapies? What are some of the practical considerations? Are there disparities in accessing these therapies? And certainly there were. And also questions regarding dietary supplements. So nice supplement article for your reference. And also, I serve on the board of the Society for Integrative Oncology, and this is a very dynamic organization. Actually, Dr. Iyengar has been a speaker for us in the past, and delivered wonderful content. So this is a great organization that kind of pools together academic resources and from all over the world. Researchers and institutions provide the latest and greatest science in the annual conference. It's the Society for Integrative Oncology, and we have also distilled these clinical practice guidelines into these educational modules. These educational modules are fantastic because they provide case-based learning opportunities, so really practical way of implementing these clinical practice guidelines. So these are free, they're available to everybody online, and they're designed to be both professional as well as patient-facing materials and resources in education. So do check out these clinical practice, these educational modules, because they're a really nice example of how these guidelines can be kind of implemented in day-to-day clinical practice. Out-of-pocket costs or the financial toxicities of accessing a lot of these integrative therapies is incredibly important when it comes to our recommendations. So please do be cognizant of this. And of course, yes, there are a lot of disparities when it comes to access, not just to integrative therapies, but supportive care therapies at large. So being cognizant of these disparities in terms of access to these supportive methods of improving quality of life are really important to keep in mind. Again, I get a lot of questions about whether or not mindfulness-based interventions are safe. Yes, they were the strongest recommendation in the guideline, but are they safe? It's generally thought that they are safe. Most participants in mindfulness-based interventions experience a sense of calm and a sense of relaxation, but it is possible for people to report unpleasant thoughts such as heightened anxiety, agitation, and discomfort or confusion, and it really depends on the facilitator to be aware of this and to pick up on this, and really also to level set expectations. I think one of the most common things in practical life, one of the most common challenges when it comes to implementing mind-body medicine interventions is that we have this misconception that when we practice these relaxation techniques, we have to clear the mind of all thoughts, and that's a very common misconception. The mind is not designed to be like an etch and sketch toy where you just kind of shake it and it goes blank. That's not what we're trying to do in using these techniques. But certainly gaining that increased self-awareness as to what is our psycho-emotional residue from one environment to the next. Increasing self-awareness is a very important and welcome manifestation of sustained practice of these techniques. So passive observation of these adverse emotions is part of the intended therapeutic process. So making sure that those expectations are communicated is incredibly important. And this is a slide that just basically summarizes what I just said. So really there are no absolute contraindications for mindfulness-based techniques, but we have to keep these practical considerations in mind. And then finally, limitations of the research and future directions. There is a significant lack of research involving cancer types other than breast cancer, and also in the cases of metastatic disease, and also in individuals from varied backgrounds. So future innovations include study design and better research methodologies, better technologies to support improved access to integrative therapies. Our next presentation is going to be giving us a real-world look into how these innovations, how innovative methods of delivering some of these recommendations can be applied via the technology that we have available. We do have support for young investigators as part of SIO. So do look at those aspects of that organization. And just in summary, mindfulness-based interventions are really supported by high-quality evidence for anxiety and depression. This was a strong recommendation for both during and active cancer treatment. Yoga really was also found to be very beneficial, especially in people who are living beyond breast cancer diagnosis. Other forms, again, a lot of this evidence, a lot of the research is in its infancy, so stay tuned for better quality research and better quality science to become available to further guide our recommendations. There are other Society for Integrative Oncology clinical practice guidelines. This is the guideline about fatigue, cancer-related fatigue, and summarizing integrative modalities that can be used to address fatigue. And of course, finally, there's also this guideline, which is the guideline that focuses on cannabis and cannabinoids. We get a lot of questions about this in our clinical practice. Should I be using THC or CBD compounds in order to improve sleep quality, in order to address anxiety, in order to improve my appetite or reduce my nausea? And again, I would refer you to the guidelines, but again, these plant-based therapies are incredibly complex, so be very careful, because the terpenes and the over 100 cannabinoids that are in medical marijuana, for example, they have a high probability of interacting with drugs and other medications. So we generally advise against using these types of compounds. But do refer to the clinical practice guidelines, and I'm so happy to be involved with this process of distilling the integrative research in order to help people improve quality of life when living beyond breast cancer. Thank you so much for your attention. I look forward to our questions and dialogue.
Thank you. Any questions?
I actually just have one question. Doc, when you're treating someone with fatigue, how do you encourage them to kind of push past feeling tired, as I saw where you say one of the recommended interventions is exercise? But when you're already feeling so draggy, like you just want a bed day, what do you say to patients? Because I'm sure that's common to kind of get them to get up.
It's a great question. And I think one of the most important principles of an integrative practice is to not allow the perfect to be the enemy of the good. And when we talk about exercise, a great example is exercise. We think of exercise as, putting on the exercise equipment and the clothes and driving to the gym and spending an hour and a half and, lifting weights and doing this. I mean, that doesn't have to be what we are recommending. So number one, don't let the perfect be the enemy of the good. Number two, we oftentimes have a tendency to compare ourselves to our former selves instead of acclimating to a new normal. Remember, instead of calling it exercise, that's why we call it movement as medicine. I tell my patients that if the chemotherapy or the radiation that you're receiving, if that's the nail, exercise is the hammer. And really, the real benefit is when we are maintaining reasonable body composition, in other words, not gaining too much body fat. Well, the goal is and I think goal setting is an incredible art. I think that having specific, measurable, achievable goals is incredibly important when it comes to coaching our patients. So don't let the perfect be the enemy of the good. Be aware of when we are starting to compare ourselves to our former selves. And go back to the evidence. What is the real goal? The goal is to maintain lean body mass, muscle tone, reduce excess body fat, and really just improve the fatigue. So you're actually, one of the best ways to improve fatigue is to exercise, yet fatigue is such a barrier when it comes to implementing an exercise recommendation. So this is where the motivational interviewing technique comes in. And this is where, if you have a multidisciplinary team that includes exercise physiologists who really are aware of all these obstacles and barriers, they can really work to empower patients to overcome some of those barriers in a very methodical and science-based way.
I have a question. There is so much taboo, but it's very important for women with breast cancer, especially estrogen receptor positive, that they are blocked the estrogen sex. Okay, let's not have taboo about that. And there is, a lot of problem. One is hot flashes and everything. The other is vaginal dryness, a lack of libido, and nobody talks and nobody does anything about.
You're absolutely
and I
right.
think it's an important, because especially young women, there is a lot of influence in their marriage.
You're absolutely
and they
correct.
should be counseled together with their husbands and see what can be done.
I agree with you 100%. Thank you for bringing this up. And I think that one of the most important things that we can do in clinical practice is to ask exactly those questions. How are you doing with intimacy? Or do you have any concerns regarding sexual health and sexual function? And once you open up that dialogue, that's actually one of the most important things that can come from this conversation, is if we do a better job asking those questions, then all of a sudden we can put together a plan. It may not be a perfect plan, but fortunately there are experts within sexual health who are even local. And I think that Dr. Mehta has done a great job of convening some of them to present and participate in these types of meetings and conferences. But definitely ask the question and then come up with a plan that is comfortable. I always recommend my breast cancer survivors to actually encourage that date night with their and to get used to that new normal, and to have their partners come in with them during these conversations so that they're both working together to acclimate to that new normal. But thank you so much for your question. It's an incredibly important and timely topic.
Okay, thank you, Dr. Mehta, for that amazing talk. I have a quick comment and then a question for you. I just have to plug there are a couple of ongoing trials testing flubanserin for sexual dysfunction in postmenopausal women on hormone therapy. So if anybody has patients for those trials, I think that'll be very important. So I really loved your comment about, and I think you made it on the panel, but creating sort of a safe space for people to bring up whatever types of alternative they're considering, to have that dialogue, shutting it down. I'm curious, on the other side of things, your conversations with colleagues and with medical oncologists or any type of oncologist. Sometimes there are barriers. The barriers are higher in those types of conversations when you're talking about integrative therapies. Although now with more data that you've seen a lot of that decrease. Do you still encounter this in your conversation with colleagues, and how?
Thank you. Great question. And we do encounter these kinds of this resistance. But the good news is that it's in my experience of the last 15 years of practicing integrative medicine in oncology environments, the resistance is diminishing. And I think that speaks to the good science that's being done by well-reputed organizations, good quality science that is being distilled now into clinical practice guidelines that are now being presented at major meetings like ASCO. So all of a sudden, there's an awareness that some of these modalities actually do have good merit, number one. And number two, we are entering an era of the informed healthcare consumer. And so before anyone calls our health system to get their cancer treatment, their cancer care, they know already what supportive services we have. They know that we have a comprehensive and multidisciplinary integrative medicine program. And actually, that becomes a way of creating that safe space, of creating that safe harbor, is because they already know that these services are provided at this location where they're going to be receiving treatment. And colleagues and in surgery are now some of my top referrers, and because they understand the value, and also there's a knowledge that this is not in place of what they're doing for our patients, but in addition to. So anybody comes in with a wheelbarrow full of supplements to the consultation, they say, "Oh, we know exactly where to go, and you're going to the integrative medicine team." And so, when it becomes part of the care design, particularly in large health systems and academic centers, that's going to have a trickle down effect to make those resistance that resistance less and less in the future. And when you combine that with good science, I think it's a very compelling care design to improve quality of life. Thank you for your question.
Wonderful. Well, I've also been tasked with transitioning us to the next session, so thank you very much, Dr. Mehta, for your great talk. So I'm going to invite myself back up to the stage. And I'd also like to invite my colleague Gil to come on up to the stage, because I don't even know why I'm carrying this microphone up here. We have got 20 microphones up here. All right, so we have a little bit of a unique session to conclude this amazing meeting today. And I want to start by thanking Sarah and thanking Dr. Mehta for giving us the opportunity to speak with you today about something really exciting that we're working on. And I think, as you heard from Dr. Mehta, we are hoping that this will offer an implementable solution, particularly in environments that may not have the types of resources, the types of wonderful resources that we just heard about, to provide whole person care and whole person survivorship care to our patients. So I'd like to share with you now what we're working on here, and want to open up some dialogue so that either later or in person, or for those who are joining us virtually by email or phone, we can chat about how this might be something that might help your practice. So with that being said, I will not introduce myself since you've heard from me already, but I'm going to ask Gil to please introduce yourself to the audience here.
Thank you, Neil. Hi, everyone. It's good to see you. I have a confession to make. I'm not a clinician of any sort, and I have been sitting through the sessions, nodding along as if I know exactly what's going on. I have been looking up things on ChatGPT to figure out what are they talking about, who is Cleopatra, and what is Paloma. I thought that's a drink. What is auxiliary surgery, and so on. But what I do know and where I'm experienced is in healthcare technology and operations, and specifically how do we use technology and combine it with the magic of human touch to deliver an experience that is really special and to deliver better outcomes. And I've spent the last 5 or so years specifically building and scaling virtual care services, clinical services. I've overseen a large care delivery organization that provided virtual primary care, virtual urgent care, virtual specialty care, virtual mental health. We did over 2 million visits a year. And so I have a lot of experience thinking about how do we provide virtual care at scale in a way that really delivers patient outcomes. I was fortunate enough to be connected with Neil a few months ago, and we discovered a common passion for figuring out how do we use technology to provide better care in the cancer space specifically, and as we'll talk about today, when it comes to survivorship and lifestyle interventions and whole person care. So anyways, that's my background. I'm really excited to be here and to learn from you, and also to share a little bit about what we've been working on.
Wonderful. Thank you, Gil. So I just want to ask the folks that are here, I don't have a way of asking the virtual audience, but I'm curious, we've heard from Dr. Mehta, and we'll be speaking about whole person care, but how many folks here are really incorporating, or at least trying to incorporate, this sort of whole person care where you're also addressing patient-reported outcomes and other treatment modalities into your oncologic treatment plans for your patients? We could just do that by a show of hands. How many people are doing that? Okay, great. For the virtual audience, I would say we have maybe about, was that 75%? Pretty good number of folks that are interested in or are implementing whole person care. And of the folks that are doing that, do you feel that you have, and this is helpful for us, do you feel that you have the resources and what you need to effectively be able to do that? If the answer is yes, could you raise your hand again? I think that's one hand. Oh dear. Okay. All right. So we do have work to do. All right. So that generally is the gist of the ASCO questionnaire that was sent out nationally with regard to whole person care. Specifically, questions were asked of medical oncologists throughout the United States whether or not people agreed with ASCO guidelines regarding the incorporation of exercise, nutrition, a lot of the guidelines that Dr. Mehta just showed. And overwhelmingly, over 90% of respondents, mostly medical oncologists, agreed with the guidelines and that this sort of care should be and needs to be incorporated into patient care plans. But in subsequent questions on that same questionnaire, oncologists were also asked, similar to what we just did here, how many folks or how many medical oncologists are able to actually implement that type of care. And the affirmative responses dropped from over 90% to less than half of respondents who felt that they could actually implement that kind of care. So it's very clear that this is a huge area of need, and we also understand that this has to do a lot with how our healthcare system is built and what's available in terms of reimbursement and so forth. So we really need to think creatively about how we can implement this type of care for our patients, because obviously it's something that not just patients are asking us for, but we all are also trying to incorporate into our care plans, and that's what we're trying to do here. So I don't have to emphasize the data on this slide to this audience. We're all well aware that we fortunately are, with better and better therapies, we are seeing a dramatic rise in the number of cancer survivors, and so some statistics listed here on the slide. But the issue, of course, is that the pace of the increase in the survivorship population, it's outpacing the availability of effective survivorship programs or programs that provide not only whole person care, but care that's unique to the needs of patients who've undergone cancer therapy. And so we're seeing a gap there in terms of the cure rates, which is wonderful, but also the care that patients need after completing their cancer therapy. And that's sort of summarized on the slide here. Again, I don't need to summarize this for the folks here, because we're all well aware that patients feel or want this type of care, but are oftentimes given little guidance in terms of how to incorporate nutrition, exercise, mental health care into their care plan, both during and after cancer therapy. And that care oftentimes is fragmented, right? Patients are chasing after providers in various areas that may not actually have an oncology focus, and oftentimes those providers don't even exist, or they're very limited, and it's hard to get access to those types of, or that type of care. We feel this too as oncology providers, of course, because as we may try to address this in clinic, we may not have the time or the staffing or the setup to be able to do this. And of course, the systems in which we work limit our availability to provide this type of care. So a lot of issues, and you can see summarized here. Of course, it can be costly as well if the appropriate solution is not provided. And so this is a major problem, this incongruency between the data, the scientific data supporting whole person care, but our limited availability or ability to actually deliver that care. And that's sort of exemplified in the statistics that you see on this slide here. About 81% of cancer survivors reporting that their physical needs are unmet after their primary treatment ends, and even more, 86%, reporting that their emotional needs also are unmet. We also see that, and this comes as no surprise to the folks in this room and in the virtual audience, that most survivors also simply don't have the access to the type of care that they need. And we also have data now that has been published and reported at national meetings that unfortunately the 5-year and beyond loss to follow-up rates particularly in the community setting, is about 50%. About half of patients are lost to follow-up once they get to the 5-year mark and beyond. And this can be a challenge because, of course, we know that long-term treatment sequelae, as well as all of the mental health needs associated with being a cancer survivor, the physical health needs and so forth, are unique, and oftentimes, even in the general medicine setting, the limited availability of practitioners in that setting, but when you do get access, may not provide the type of specific care that cancer survivors need. And when we do try to provide survivorship care ourselves, of course, this is a challenge, right? Because speaking from the medical oncology perspective, we're really focused, of course, on that acute cancer care, right? And as many of you know, my specific research area is to look at lifestyle interventions. But even with that research interest, when you're in the trenches in clinic, it's a real challenge to be able to go from somebody who has metastatic progression of their disease to the next person and try to talk to them about what they should be doing in the post-adjuvant setting 10 years out with their diet, for example. So I think it's a challenge, and this we've got data indicating that this contributes to problems with clinic flow, provider burnout, and so forth. And of course, this can be a challenge in terms of delivering cost-efficient care. Actually, Gil, you can speak a little bit more to this.
Sure, yeah, we've spoken to various practices, and the themes are the same everywhere. It is budgets are tightening. It's hard to justify additional types of care, like things that would fall in the whole person survivorship care bucket. There's a lot of recognition. Every single oncologist we've spoken to said, I wish I could deliver whole person survivorship care. I wish that my practice would be able to do that, but it's just unaffordable. It is too expensive. It is really difficult for us to do. Neil mentioned the loss to follow-up statistic, which for us was really eye-opening. And a major driver of that is the reality that there isn't a lot of post-treatment support for patients coming from the practice because of these reasons that we just talked about. And so when patients disengage, they disengage for the long term often. Some come back, of course, but there's also a downside for the practice, both in terms of continuity of care and in terms of actual patient volume and being able to treat folks and ultimately revenue as well.
Okay, and so that being said, we've sort of established the problem here. We do know that a high-quality survivorship care does improve outcomes, and this is partly why IOM and other organizations have really prioritized the need for high-quality survivorship care. Certainly when it comes to physical function and physical health, we see improvements. Mental health with appropriate survivorship care that specifically addresses cancer survivors also improves. And then we also know that because of this data, a lot of institutions, large cancer institutions, do have established survivorship programs, but even there's some challenges in terms of actually getting patients into their programs. In addition to the long-term outcomes, we also know that effective survivorship care, an important component is screening, right? Screening for new cancers in addition to looking for recurrence. And we do see that screening for cancer survivors, where there can be a higher incidence of certain secondary cancers, we see improved screening rates and earlier detection with effective survivorship programs. So how do we mitigate this need to implement effective survivorship programs? And that's really our goal here. So what we're trying to do here with Dawn is offer practices, particularly practices that are in limited resource environments, but really I think a lot of settings could benefit, is offering a care team really that is embedded within the practice to deliver this type of effective whole person survivorship care that is evidence-based. And this is meant to be done in a cost-effective manner, which will show you the model for doing so. So again, we had some nice data presented by Dr. Mehta in terms of how to accomplish that type of whole person care, and that's what this slide is really summarizing here, is that there are many components: sexual health, nutrition, exercise. We've talked a lot about mental health, but simply coordinating all of these parameters, right? That's another big challenge, is care coordination, and making sure people are getting consistent messaging and not inconsistent recommendations from their various providers. This is all really critical, while also making sure it's in line with what the primary oncologist is recommending as well. And so this is our model here. This is essentially a model that uses a risk stratification instrument to really individualize care and understand the individual needs of a patient. And that care is delivered through an MD-supervised APP who's trained not only in survivorship, but in essentially lifestyle care. And I say that also noting that when I've developed similar programs like this, the real goal is to rapidly translate the evidence base into clinical practice. Oftentimes the guidelines, and it's not just for lifestyle management, it's for therapeutics as well, the guidelines don't rapidly reflect what we're seeing or publishing in the scientific literature. So with a flexible model, clinical model like this, we can rapidly translate those findings into clinical care. And this is done through a multidisciplinary care approach, including a care coordinator who's dedicated to the platform, behavioral health manager as well, that is overseen by a psychiatrist, and some additional add-on multidisciplinary providers to help support the primary oncology practice.
I'm
So,
also realizing, if I may just add, I'm realizing none of the slides made it really clear what is very obvious to us, but may not be obvious to others, is that this is a virtual platform. So all these folks are connected virtually. It is easy to access for patients. It is easy for us to be able to service different geographies, different practices. But I just wanted to clarify that point because it's an important one.
That's a very important point. Thank you for clarifying that. So I want to show you sort of the core components of the program, and that is to not only provide traditional survivorship care, but we all know that these types of whole person interventions are important even during cancer therapy, and there is now a large body of published data to support that statement. In fact, of course, the NCCN and other bodies define survivorship, cancer survivorship, as starting at the time of cancer diagnosis. So that's one of the core components here, is onboarding patients at or close to their time of diagnosis, but also offering a flexible onboarding for those patients or providers who think that this should occur, or patients should come on or enroll a little later, perhaps after their acute therapy. But most of the data point to the importance of really engaging early. I mentioned earlier this sort of risk stratified care. So I think this is essential. We know that handing people a pamphlet or just telling them you should go exercise or you should go eat healthy, it doesn't work, because what does that actually mean? And we don't tell our patients, you know, you should go take some pills for your breast cancer. It's the same thing when we do that in lifestyle approaches. So we really need to provide individualized care, and we now have evidence guiding us in terms of how to do that. So that's what we do here, is we use an instrument that allows us to understand what parameters a patient is at risk for in terms of all of those parameters I showed you on the previous slide, and then how we can construct a care plan for that patient that prioritizes those particular areas of risk or need, because we also recognize that patients and providers are dealing with multiple competing priorities, particularly around the time of cancer diagnosis. So that type of risk stratification is really necessary. We also recognize that their needs evolve through the cancer journey, and the needs a person has after cancer treatment is concluded may be different than at the start of cancer treatment. So this can't be a static plan. We know that the original survivorship care plan model failed because it was a piece of paper that you handed to patients, and it didn't change. So this is a dynamic digital plan that changes as the patient needs change as well. So I want to show you some data that we reported at San Antonio from a precursor program, or a prior program. About 5 years ago, I founded the Healthy Living program at Sloan Kettering, and I believe I discussed it at this meeting maybe about 3 years ago or 4 years ago, right when we were really quite nascent, so we didn't have this data. But essentially what we showed was that the needs of our patients, actually many of them are pre-existing. They exist at the time or around the time of diagnosis. And that was one of the big learnings from this data set, that we're not necessarily creating these needs through our cancer therapy. We can certainly exacerbate these needs, but a lot of this is pre-existing. And that's the problem with the current traditional survivorship care model, is that if we wait until years out after diagnosis, we're really letting many of those needs go without being addressed that are already in existence for many years, maybe even prior to the cancer therapy or the cancer diagnosis. Secondarily, as I mentioned, we know that several of those needs are exacerbated by cancer therapy, and so the prioritization changes again. And this is why we need to be continuously reassessing what are those risks, what are those needs. These were the top needs that we identified in a cohort of about 1,400 patients that enrolled in the Healthy Living program. As you might not be surprised to see that actually people really wanted supplement counseling. And I think that has to do with some of the marketing that's out there, some of the questions people have, and us as clinicians also wanting to make sure that folks are not doing things that are unsafe during their cancer therapy. Sleep counseling was the second most prevalent need, exercise, behavioral health, sexual health, and so forth. And then we also looked in a subset of patients that enrolled in the program. We looked at patient-reported outcomes. And so for those of you who do work in this area or are familiar with PROs, these, as you know, are all very standardized, validated instruments to assess multiple different parameters of quality of life. And essentially what we saw with the Healthy Living program approach, which is very similar to the model I described here, is that nearly every single one of these parameters improved. And this was at 6 months. So this isn't, I'm not talking about a year or two out of intervention. This was pretty quickly. And I think a lot of this was simply addressing the need can induce a lot of improvement here. And so these data were presented at San Antonio and at ASCO, and we'll have it out in a manuscript shortly that is soon to be published. But I think it is really helpful and really solidifies what everybody here showed us by their show of hands, that this kind of whole person care does have an impact on our patients. So I know we're running kind of low on time here, so we're going to wrap up here. I'm going to hand it back to Gil to sort of really summarize here what this virtual platform can do, and then we'll leave you with some contact information so that we can engage with you one-on-one. Please feel free to come up to us if you're here in person, or for those that are virtual, please feel free to email us, and we'd love to tell you more. But Gil, could you please just walk us through sort of a summary and what we can do?
Yeah, I have a couple of slides on kind of benefits to patients, oncologists, and practices that I will not run through line by line, but maybe just to summarize, I think what we're excited about for patients is for them to get an actual care team that is focused on survivorship, that is comprehensive. It is not a piece of paper. It is an actual team that manages their symptoms, lifestyle changes, all that sort of important inputs into their ability to live a productive and happy life. We also highlight the integrated care team, the fact that the team actually works together and is coordinated, and coordinated both internally within the survivorship team that we had seen, but also together with the primary oncology team, so everyone's kind of on the same page about what's going on. And maybe the only other one that the other two I would mention are the bottom two, which is rapid access to symptom and pain management. So patients can always get support for their needs, no matter how many years it's been or no matter what time of day or night it is. So that is an important component of our program. And then lastly, this is truly foundational to how we designed the program. We wanted this to be either free or at very low cost to the patient. So everything that we do is our services that we are certain we can bill to insurance. Yes, there will be copays. It's practically impossible to make this completely free, but our goal here has been to make it really, really affordable, so that patients are not already, after having dealt with the financial toxicity of the cancer treatment itself, are not hit with, thousands of dollars of bills just trying to get good survivorship care. Quickly for oncologists, I think we kind of touched on this. Maintaining the efficacy of the intervention obviously is really important long term, and enabling oncologists to just have more time to spend on complex cases, on higher acuity cases, on folks in primary treatment, and time that today is kind of spent off the side of their desk trying to provide survivorship care as best as possible. Yeah, we can flip to the next slide. And then lastly, we want this to benefit the practices as well. Obviously, better patient outcomes are good for the practice in a bunch of ways, and very tangibly in terms of higher retention rates and more referrals. But also, coming back to that 5-year follow-up, loss to follow-up point, by maintaining a relationship and supporting patients in remission through survivorship, if there is a recurrence, we're able to make sure that they get referred back. So we're kind of keeping them in the practice ecosystem and keeping the care in a continuous way. Maybe I'll just touch on a couple more to sum it up. There's an ability for the practice to hit their MIPS measures more effectively if we're able to provide survivorship care on their behalf, which helps with Medicare revenue. Some of you will know this. Reduces burnout and actually allows the practice to talk about a more expanded scope of services that patients, as they consider where to go, might choose that practice as the place where they get their treatment. And importantly, it also makes survivorship, which everyone thinks of today as kind of a cost center, like, oh, I can't afford another nutritionist, I can't afford another social worker, I just don't have the budget. It makes it from a cost center into an actual service that brings in revenue into the practice. So that's a very important shift in paradigm that, as we all know, financial incentives have to be aligned in order for anything to scale. And so this is something that we're very excited to be able to offer practices.
Yeah, so I was really, thrilled about this model because, one of the things that really is challenging for me is I'll go on these panels and I'll describe our very complex exercise clinical trials and nutrition clinical trials. And then the one question that I always get at the end that always kills me is, yeah, this is great, but I don't have any of these resources, so how do I provide any of this care? And so that made it very clear to us that we really had to come up with a platform that is accessible and provides this sort of care in an accessible way to patients, but also to practices and oncologists. So we'll leave you...
There's one last slide.
Yeah, please.
Which is just to say, none of this would work if it's hard for the practice to integrate these services into their workflows and into their ability to work. We cannot take many months and many resources to implement something like this, so we've devised a pretty low-lift way to integrate this offering into any practice's workflows. Most importantly, as we're working out of your EHR, we are there with you, we're messaging with you in the portal. We're truly like an extension of the care team. We're submitting our documentation in there, we're submitting our codes in there, and our billing through the EHR. And lastly, if you do have resources dedicated towards survivorship or resources that currently support survivorship, perhaps you have a nutritionist, perhaps you do have a social worker or a physical therapist, we're able to flex our model to make sure we can work with them so that it's very clear who to refer to when and whose job is to do what and so on.
Yeah, thank you. That's really important, sort of the how does it actually work solution. So that's, it in a nutshell, very, very brief. We didn't want to keep you here too long, but really grateful for the opportunity to be able to present this to you and would love to hear your feedback as well. So please contact us. Here's our information. We'd love to chat with you more. If you're interested in implementing this in your practice, please also get a hold of us because we'd love to work with you as well. So I will stop there. I will say thank you for your attention to this session. And then I think we're also going to be closing